Thank you, Dr. Sharma. Thank you, colleagues, for joining. So I really hope to convey over the next 20 minutes the central role of the mineralocorticoid receptor and its activation in the pathogenesis of cardiovascular and kidney diseases, and highlight the importance of its antagonism in traditional drug development has focused on individual disease states such as chronic kidney disease, heart failure, and type 2 diabetes, but we know in clinical practice these conditions substantially overlap in individual patients. Thus, individual drugs that can target multiple mechanisms of actions and pathological drivers may be beneficial to broad cohorts of patients. And in fact, we now understand that combination medical therapies has now become the standard of care for multiple chronic conditions, including in heart failure and chronic kidney disease. And I'll highlight that the mineralocorticoid receptor antagonist, or the MRAs, are chief among them and are common as foundational therapies in both these chronic conditions. We also have understood that hyperaldosteronism, or aldosterone excess, is very common in the community. This is a nice cross-sectional study across 4 medical centers of over 1,000 patients in which routine testing after an oral sodium suppression test identified that the prevalence of hyperaldo states can vary from anywhere from 10 to 20% depending on the degree of hypertension. So this is very common. This is not a really isolated cases of secondary hypertension that we're seeing, but really on the spectrum of essential or primary hypertension. And the authors concluded that the prevalence of primary hyperaldosteronism is high and largely unrecognized. There is a prevalent continuum of renin-independent aldosterone production that parallels the severity of hypertension, and that these findings redefine that primary hyperaldosteronism syndrome and implicate its pathogenesis even in essential hypertension. The MR story, or the mineralocorticoid receptor story, is really decades long and started in the 1940s, in which this elegant experiment of of DOCA, which is a mineralocorticoid receptor activator in rats, showed that the activator in the presence of high salt diet allowed not only for high blood pressure, but also facilitated progression of hypertrophy and fibrosis in the heart and kidneys. This then led to it took over about 50 years for the initial trials of MR antagonists in heart failure and chronic kidney disease, and we'll review those shortly. So in heart failure with reduced ejection fraction, 3 seminal trials have really established these drugs as foundational therapy, not only improving survival, reducing heart failure hospitalizations, and even improving health-related quality of life. The initial trial was called RALS. This was in patients with NYHA class 3 or 4 heart failure with significant impairment in LV function. This trial was a modest-sized trial, but showed improvement in overall survival in these patients. This was later extended in the emphasis trial, which is on the far right, into patients with more mild heart failure. This is NYHA class 2 predominant heart failure, and again showing that these drugs improve health status and survival even on established background therapy. The middle trial, emphasis, was a unique trial of post-MI LV dysfunction or diabetes. This trial again showed that MR inhibition early after myocardial infarction is important, not only to delay progression to heart failure, but also to reduce sudden death early after MI. Spironolactone has also been studied in heart failure with preserved ejection fraction. This was an NIH-funded trial across 6 countries. And this trial overall showed a non-significant reduction in its primary endpoint of cardiovascular events and cardiovascular death. However, there was important regional heterogeneity in which in the Americas there was a substantial reduction, and in fact that has now influenced clinical practice guidelines such that spironolactone is recommended as a class 2B recommendation, could be considered in those individuals with heart failure with preserved ejection fraction. So we'll shift gears now to later generations of the MR antagonist. We've discussed spironolactone and eplerenone, and these were initial generation MR antagonists that are steroidal. They have unique properties. Spironolactone is highly potent, but has low selectivity. It's a dirty drug. It influences multiple different receptors and has multiple metabolites. And it has high tissue distribution in the kidneys compared to the heart, and thus has related electrolyte disturbances such as hyperkalemia. Eplerenone is more specific, has more selectivity to the MR receptor compared with other androgen receptors, has less sexual side effects such as gynecomastia, and is a little bit more balanced in terms of kidney and heart tissue distribution. The last generation is finerenone. This is a non-steroidal molecule. It's a different molecular structure. This is not only highly potent, but also highly selective to the MR receptor. It has no clinically relevant metabolites and is very balanced in terms of the heart and kidney, and so at least theoretically there may be less electrolyte issues such as hyperkalemia. The inhibition of the mineralocorticoid has been perturbed by hyperkalemia and has really limited its broad implementation in populations at risk. And so the question becomes, can we block MR but still not cause hyperkalemia? So finerenone was developed for just that purpose. This is a bulky non-steroidal molecule that's highly selective and potent, and it has a distinct structure from its predecessors. We also know that in chronic kidney disease specifically, there have been therapies that have target other pathways such as hemodynamics and glycemic control, but inflammation and fibrosis, a critical component of pathogenesis of chronic kidney disease, was left undeterred, and that's where the MR antagonist really filled that void. So finerenone has now been studied in large-scale clinical trials across the spectrum of kidney disease in type 2 diabetes. This is the KDIGO heat map that many of you may be familiar with, in which on the x-axis is albuminuria from A1, A2, A3 with increasing degrees of albuminuria. And on the y-axis is GFR categories or stages based on, as you move down, further decrements of eGFR. So there were two pivotal randomized clinical trials, Fidelio and Figaro. These were trials that generally studied advanced stages of chronic kidney disease with high degrees of proteinuria and at least modest reductions in eGFR. And the combined cohort really encompasses over 13,000 patients in this pooled fidelity analysis, which we'll review. So when taken together, these trials showed that finerenone, on the background of maximally tolerated renin-angiotensin system inhibition, slowed kidney disease progression in this high-risk population of chronic kidney disease by about 23%. And this is the breakdown of those kidney disease endpoints. And I'll highlight the main one that's perhaps clinically relevant to your patients. End-stage kidney disease, that's requirement of dialysis or transplantation, was reduced by 20%. So in terms of context for our own patients, the absolute risk reduction was about 1.7% over 3 years, so about a 23% relative risk reduction. So about 60 patients would need to be treated for 3 years to prevent one important kidney disease outcome. The safety profile was quite favorable. This drug had modest blood pressure lowering, on average about 3 points in this high-risk cohort. There was no really clinically relevant A1C or body weight changes, no increased incidence of acute kidney injury, and sexual side effects were rare and balanced. And we'll review hyperkalemia in just a moment. So for your practical purposes, this drug is now FDA approved for chronic kidney disease. It exists in 2 doses, 10 milligrams and 20 milligrams, can be initiated in any individual with a potassium less than 5. And you initiate the 10 or 20 based on your baseline eGFR. You check potassium again in 4 weeks, and you can modulate that dose. You can up-titrate the dose to the highest dose of 20 milligrams, and you can modify the dose subsequently if the patient experiences hyperkalemia. So I want to take you through some of the practical aspects in general of MR antagonism in heart failure and chronic kidney disease. First and foremost is blood pressure is chief determinant or allocation of therapies in chronic conditions. And the MRAs have a unique property. They have almost a titratable property in which at high blood pressures, including in resistant hypertension, these are quite effective antihypertensive therapies. But at low blood pressure in our high-risk patients, for instance, with heart failure with reduced ejection fraction, these therapies are actually hemodynamically neutral. They do not cause clinically relevant hypotension, and they don't lower systemic blood pressures. In addition, these drugs have unique properties with respect to subsequent eGFR. We're very comfortable and familiar with this so-called eGFR dip, or the expected decline in kidney function after initiation of an ACE inhibitor or an ARB. And we've seen similar patterns of an early reduction in eGFR after initiation of an SGLT2 inhibitor. And I'll highlight that the very same reduction is seen with initiation of the MRAs. These are 2 of the pivotal trials, Emphasis Heart Failure and TopCat. You can see within days to weeks, you see an expected early decline in eGFR. This is not related to kidney injury. This is a hemodynamic effect at the level of the glomerulus related to early reduction in glomerular pressures, and is thought to be a chief determinant of actually the mechanism of benefit of these therapies in delaying chronic kidney disease progression. And upon stopping the drug, this is a reversible change, and so does not actually impact the long-term trajectory of kidney function decline. So hyperkalemia is the most important adverse event associated with the MRAs. And early after the publication of the first pivotal trial of the MR antagonist RALs in Canada, there was a large-scale experience at the population level of an increased incidence of hyperkalemia, hospitalizations, and even death after dissemination of these results. And so that has really prompted substantial change in our clinical practice of how we approach and monitor hyperkalemia. Reassuringly, more recent data, for instance, these data are from Medicare from 2013 to 2018, after dissemination of more recent trials like TopCat in heart failure with preserved ejection fraction, has seen that while there's been increasing use of spironolactone in the target population in the blue line, in the bars, you see that the rates of clinically significant hyperkalemia hospitalization really have not changed. They've been steady despite broad implementation. So how does finerenone, the latest generation, actually impact potassium? There's a very modest increase in potassium that occurs very early and is reversible upon stopping the drug or with dose reduction. And with respect to clinically significant hyperkalemia events, see that any hyperkalemia is increased. There was 14% in the treated arm compared with about 7% in the placebo arm, so doubled the rates of hyperkalemia. However, on the right hand, you can see that rates of hyperkalemia leading to, for instance, hospitalization or death were very low and, in fact, relatively balanced between groups. Who are the people that actually develop hyperkalemia? Not surprisingly, these are patients who have already baseline elevations in potassium, as well as reductions at the lower end of the kidney function spectrum, or at highest risk for developing hyperkalemia to the MRAs. So the frequency of potassium monitoring does vary by the type of MRA. The predecessors, the steroidal MRAs like spironolactone and eplerenone, you can see at the bottom, it's recommended to monitor as early as a week to 2 weeks upon initiation. Finerenone, because of its more modest effect on potassium levels, the trials as well as the FDA labeling recommend 4 weeks after initiation can be checked, maybe allow for more pragmatic use of this therapy. So how does finerenone compare with the other therapies in the class? Are there true differences in risks of clinical events and potassium? Well, this has not been well studied. There have been phase 2 studies that have been comparative evaluations. Listed here are 3 such trials, and you can see on average, when compared to spironolactone, finerenone did lead to less hyperkalemia. Compared to eplerenone, it's about similar. Compared to placebo, we did see that there was a modest increase in potassium levels. So finally is the concept that MRAs can be easily combined with other therapies. And so this has been repeated in multiple randomized clinical trials, but this is one such example in which the benefits of the MR antagonists do not vary based on background therapies. Here you can see that even patients on very low dose or maximally tolerated doses of the beta blockers or ACE inhibitors benefit just the same with eplerenone compared to placebo in the EMPhASIS trial. Furthermore, there may be actually synergistic potential between therapies when used in combination in chronic medical conditions. These are data in the heart failure trial called DAPA-HF, in which patients treated with an MR antagonist had lower risks of hyperkalemia with the SGLT2 inhibitors compared with placebo, and suggest that you can actually maintain MR antagonism in these patients and lower clinically significant hyperkalemia events. Furthermore, the exact same has been seen when combining an ARNI, sacubitril/valsartan, with an MR antagonist in which there's lower potassium levels in patients treated with the combination compared with, for instance, an ACE inhibitor and an MR antagonist. And that actually, in that trial, there was actually fewer discontinuations of MR antagonists in the ARNI-treated group, in the sacubitril/valsartan-treated group. So this is an effective therapy that can be combined with other essential or foundational therapies in chronic conditions. So this space is going to rapidly increase in terms of our knowledge about MR antagonism in CKD and heart failure. The first 3 trials here listed here are in heart failure with preserved ejection fraction and mildly reduced ejection fraction that are poised to report in 2022 to 2024. There are 2 SPIRIT trials that are evaluating spironolactone in HFpEF to validate and to confirm the findings in the TOPCAT trial. And then Fine Arts is a large randomized clinical trial of 5,500 patients of heart failure with preserved ejection fraction. That is an endpoint-driven trial to evaluate finerenone in that population. And then finally, FIND CKD was recently announced. It's a 1,500 patient trial that's based on a surrogate endpoint of eGFR changes, but studying non-diabetic patients with chronic kidney disease. The really foundational Fidelio and Figaro trials evaluated diabetic kidney disease. We discussed the really potential, theoretical and actual potential for synergy between drugs, and now these are actually being now tested together in combination. There are SGLT2 inhibitor MRA trials that are underway in heart failure. This is a trial called Miracle, in which it's testing novel MR antagonism with dapagliflozin at varying doses in combination or alone. Similarly, these combinations are being tested in chronic kidney disease. So we'll learn not only about these therapies in new populations at risk, but we'll also learn how they can be effectively combined with other therapies. So to conclude, mineralocorticoid receptor overactivation is a central driver of progression of heart and kidney disease. The steroidal MRAs, spironolactone and eplerenone, form backbone therapy for heart failure with reduced ejection fraction, but do potentiate hyperkalemia and some androgen-related side effects. The non-steroidal MRAs, such as finerenone, slow kidney disease progression in CKD in the presence of type 2 diabetes, and may have lower risks of hyperkalemia. The MRAs can be effectively combined with other therapies in heart failure and chronic kidney disease, and ongoing trials will expand our knowledge of this class, evaluating finerenone in HFpEF as well as non-diabetic CKD. So thank you very much. I look forward to the discussion to ensue.